already past 3:30. So we need to go to the breakout sessions. And again, I'm making the appeal. The poster presenters, please, you can edit there and let the delegates reconvene for the next session. The afternoon sessions has only just 5 presentations. In Ziba Hall, where we are now, Dr. Stephen Pandey, the regional referral, the director for Moroto Regional Referral Hospital, will be chairing this session here in Ziba Hall. And I'm happy to note he's already here, he's marching forward. And then, of course, in the Kama Hall, it will be Dr. Charles Achia. We will also be chairing in Kama Hall. And of course, the thematic areas are the same, so you can always split. We expect the delegates to split accordingly, like we have been doing. We are going to, the thematic area for the afternoon for both breakout sessions is improved service delivery models. So I'm just making a roll call for the presenters to make it very simple for my brother Stephen. Nabala, Esther Nabala, where are you? By show of hands. Nabala Esther, please come forward on this first table. First table, please shift. Emma Waireke, Doreen, please come just now. Then Aisha Nasanga. Okay, we are putting a star. Then Stephen Upal. Okay, thank you. Take up this front row, please. The presenters have already read out. Please, can you come? In fact, come to the middle one. You want the seat where the minister was seated yesterday, and the director. So, no, take up that. Can the other presenters have already mentioned come forward, please? Just take up this middle seat. Here. Then Stephen Upal. You are the one, okay, fine. Tandiswara, Tom, okay. So they are all here. I can't roll call the other ones in Kama Hall because I know they would have already moved there. The poster presenters, can I request Julius, will you just help me to end the poster presenters should end because the hall is now going to do another activity. Please, delegates, let's respect the time and procedure set. After the breakaway sessions, you will be able to come back to the posters during the evening tea and coffee break. Please, let's end it there. So without much ado, allow me invite Dr. Stephen Pandey, who is the director, Moroto Regional Referral Hospital, who is going to chair this session. I have already assembled your panelists, so it makes life easier for you. And over to you. Thank you. You're most welcome.
Thank you so much. Yeah. Good afternoon, colleagues. Yeah, thank you very much. I take this opportunity to chair this session. As we know, the 10th theme for the QI emphasizes strengthening health systems for improved quality of health care. So, health care delivery is the gist of the matter. This is now the time for us to look at this and see whether the delivery is effective, efficient, equitable, and also responsive and accountable. Of course, service delivery is an outcome or an output of governance and leadership and other health system building blocks. So we are going to look into this and see how much of our systems have been strengthened to deliver quality health services. So without Taking any much time, I want to right away go and call upon the presenters in the order they were called. That is Nambala. Yes. To come and start the presentation. I'm giving you 10 minutes each, and we must strictly follow the 10 minutes. Isn't it? Thank you. So, Nambala.
Good afternoon, ladies and gentlemen. My name is Naloge Prosi. I work with Mbale District Local Government in a small facility called Bunampong Health Center 3 as an in-charge. I'm a public health specialist and a district QI focal person. I bring you learnings from Bunampong Health Center 3, where our project was towards improving attendance of PNC at 6 days. I acknowledge my co-authors in the list below, and most importantly, the IPs that have supported us throughout the journey. IT, please. Okay. PNC is care for both mother and baby after delivery in the cascade of 24 hours, 6 days, 6 weeks, 6 months, preferably up to a period of 1 year. By definition, maternal mortality is defined as death of a woman during pregnancy, delivery, or within 42 days of termination of pregnancy. In the recent report from the Uganda Demographic Health Survey of 2022, we registered a decline to 189 maternal death rate per 100,000 live births, and we also managed to pull down the neonatal mortality rate to a tune of 22 per 1,000 live births. Data review in one of our monthly audits were able to note that as far as Bunampong is concerned, in PNC attendance at 6 days, we had zero contribution to the successes reported in the DHS 2022 in the 3 subsequent data reviews of November, December 2022, as well as January 2023. So the team set out to improve the uptake of PNC at 6 days from 0% as of January 2023 to 80% by July of 2023. ICT. In our assessment and review of the gap above, we used the QI tools. We used the flow chart to understand our client flow, and we noted that as far as screening is concerned, it was one of the missed steps throughout our client flow in the facility. Then with the fishbone analysis, we noted that the appointments that were given to our clients at discharge after they had given birth were unclear. We would simply tell them, return after 6 days. That message never sank well to our clients. They would not competently count off the 6 days to come at the dot of the 6th day. Then we also noted issues of non-documentation. Some mothers would enter through facility, receive services for both their children or newborns and for themselves as well, but documentation in the registers, that was the PNC register, which is the source data document, never happened. The non-involvement of the community structure, specifically the VHT, was not also very well grounded. Then also in my catchment population, our catchment population of Bungoko sub-county is quite big. We serve about 18,000 population. And unfortunately, the most heavily populated parish is very far away from the facility, about 10 kilometers also away from the facility. very far away but very heavily populated. So that also we noted as a gap because they could not easily access the facility that they are intended to. So in the things that we did differently, one of it was to adjust our client flow to include a step for PNC screening. And that alone, that simple adjustment of including a step pushed us from a 0% in January to a 27% in a span of just 1 month. Writing clearly for a mother the actual date and the day of return also moved us from that percentage to 45% in 1 month's time. As far as improving data quality is concerned, we instituted cross-checking daily the PNC register with the tallies that the screeners would have at the triage points to be sure that whichever client eligible was identified actually received the service and was documented. That data quality check measure managed to push us from 44 to 65%. So in blue, as you see, is the attributable improvement for that change. We also went ahead to attach VHTs to facility, recognizing and incentivizing those that were outstanding in terms of performance. But unfortunately, that did not work well. It instead caused a decline in performance for reasons that the farthest parish, like I earlier mentioned, the VHTs would not comply to come to the facility due to challenges of transport. But also the referrals that they would make never reached for reasons that are similar. So as a way of addressing that, we never actually dropped the change. We made a little of the modification by attaching the VHTs to the nearest facility. We created an outpost in the farthest point in that parish where we could attach these VHTs, and the referrals too were being made to that outpost. The outpost operates 7 days in a week. We have human resource, key midwife attached daily, and then we routinely visit for support supervision as the mother facility. That has been our biggest improvement change. As you'll see in the run chart, our working denominator are the mothers that are giving birth, expected to be giving birth. That enables us to capture even those that have not necessarily delivered from our facility, but we expect them to come for PNC at those time intervals earlier mentioned. So November to Jan was our baseline data collection. Improvement work started around Feb, and you see we increased, but there was a decline that came about due to issues of compliance of VHTs, attachment to the different sites due to transport. But we later stabilized when we created an outpost called Kamoto, where we are able to operate all throughout the days of the week. In the picture above is the usual health education session being conducted by the VHT. Because they are now fully involved even in the facility work, we are able to build their capacity in terms of what we need to have them do in the facility and the community as well. So we have managed to push improvements in PNC attendance to currently above the expected target of 100%. In discussion, PNC is a critical phase where we are able to even continuously identify the high-risk mothers and their babies and timely address them. It provides an opportunity to monitor and address potential complications as well, and in facilities, earlier intervention reducing maternal and neonatal mortality rates, which is our aim as a country. Next. What do we learn from this sharing? Data review is very critical. Involvement of the community structure is equally good, but also establishing constant outposts in the farthest underserved communities within your catchment does magical, because when we extend services nearer to the consumers, the uptake and the utilization improves in the long run. So PNC 6 days has enabled us to identify, among other things, unhygienic sanitary practices, which we are able to address through counseling. In conclusion, health facility quality improvement is an indispensable endeavor that holds the potential to revolutionize healthcare delivery. By prioritizing systematic assessment, evidence-based interventions, and ongoing monitoring, facilities can elevate the standard of care we recommend as a team of Bunampong that there is need to reduce service access barriers by increasing predictable outreaches to the communities that are less advantaged in terms of accessibility, infrastructure-wise. I want to acknowledge the support of my dear VHT team, Bungoko Sub-County, my team, Bunampongo, for the work well done, the support supervision team from the district, the implementing partners, in particular, individually, Esther Nambala, our regional care officer, Dr. Andrew Katawela for support, the mentorship. We are very grateful as Mbale District. I thank you.
Thank you very much. A big applause to Munapogo. A big applause to the presenter. Thank you. So the next presenter is, please take a seat. Come here. So the next presenter is Emma Welike Doreen Rebecca, who is going to tell us about utilizations of hands-on didactic mentorship to improve treatment of women with cervical precancerous lesions at private, not-for-profit health facilities. So the floor is yours. Thank you.
Thank you very much, moderator. Good afternoon, everybody. My name's Emma Welihe. I work with USID, a local service delivery activity implemented by Uganda Protestant Medical Bureau. And I'm going to take us through our work on utilization of hands-on didactic mentorships that majorly focused on improving treatment of cervical cancer, precancerous lesions rather, among women that receive RT care from the PNFPs supported by the LSDA activity. So just key to note is cervical cancer is a gynecological cancer with quite high mortality rates of about 55%. And we noted that a lot of work has been done around cervical cancer screening and treatment, but particularly still existent gaps were around documentation, thorough documentation for the positive precancerous lesions, but also treatment, in addition to even screening. Among the key issues we also noted, have been noted capacity of health workers, particularly around treatment of the precancerous lesions, vis-a-vis also access to equipment. And just to throw light on the context of equipment, as Uganda Protestant Medical Bureau, particularly for the LSDA activity, we support 138 sites across the 7 sub-regions, USID sub-regions. That's Karamoja, Busoga, Bukedi, Acholi, Ankole, Chigezi, and Lango. And we note that out of the 138, actually about 46 are able to access all the equipment, including thermocoagulators. So the equipment, the issue of equipment really, that brings it out much. And in March 2023, we noted that as an activity, we had actually only supported the facilities to ensure treatment of women with precancerous lesions of 67.3% of the 251. And that was quite shy of the target that we had to achieve. Now, among before the methods, among the key things we noted were the fact that our majority of our sites actually had equipment issues, but also challenges around capacity, majorly around treatment, and very, very importantly, documentation. So what we did, among the things we did, is ensure that facilities with capacity gaps, following, of course, the needs assessment, we noted that those with gaps in treatment of precancerous lesions had to be attached to a routine a technical person to have continuous capacity building done. So we identified regional mentors in the 7 sub-regions, as I'd earlier highlighted, and these were attached to the priority sites, focusing on sites with gaps in treatment, but also sites with suboptimal yield in screening. And then as well, we worked with those sites to ensure that we identified community health workers from within the facility to ensure that they mobilize the women that had pending treatment for cervical cancer lesions. Now, Among the sites included both the sites that are particularly VIA sites, but also those that are HPV testing sites, and some that actually do both. So thereafter, we noted, of course, the issues of equipment were an issue, but the thermocoagulators, though only at 46 facilities, the roving mentors or the regional mentors that we got, we supported them to conduct support through a roving approach, while utilizing the thermocoagulators from the facilities that had them to ensure that they touch base with the facilities that had gaps in treatment, to support in treatment, but also while supporting treatment, as well as orienting and building capacity of the health workers to also be able to actually provide treatment, but as well as really improve their quality of screening to identify all the women with precancerous lesions. This was done for all the 56 sites that actually had gaps in treatment at the moment. And as well, we noted that the mentors, among the emphasis was for them to as well conduct data quality assessments, so that we're able to see to it that the work done is actually documented, but also as well reported, especially through the routine reports, starting from the weekly PRS to the monthly reports. We also, in the different sub-regions, created regional WhatsApp groups, majorly comprising the facility teams together with the roving mentors, the regional mentors, with cervical cancer persons, of course, together with the in-charges and the technical LSDS staff that provided critical routine updates, but also summaries and continuous capacity building also through those interactions on the WhatsApp groups. Now, from the 67.3%, and this is focusing on treatment, we noted that there was an improvement in treatment. You will see that the follow-on quarters of April to June and July to September, we supported the facilities to treat more than 100%, compared to 67% October, December. And by the end of the program year, that's October 2022 to September 2023, we managed to support treatment of women with precancerous lesions to 93.8%. Majorly attributed to the roving mentors being able to move with this equipment and support timely treatment, as they also built capacity of these health workers to also have hands-on, honestly, orientation as they adopt the skill and continue providing the service. Recommendation majorly, we're looking at use of roving mentors in a resource-limited setting, the supporting continuous capacity building for health workers, not only on treatment, but also screening, as I highlighted. And of course, the advantage of them moving with thermocoagulators provides an opportunity for didactic coaching, as we provide timely treatment of these precancerous lesions. Also, adoption, of course, of integration of cervical cancer services and in all the ART care points provides an opportunity for timely screening and treatment of eligible women, or even referral for those advanced cases. We do acknowledge support from USID, the district health teams, the facility leaderships and management of the different facilities, in addition to the community structures that we work with. Thank you very much, Madrid.
Thank you very much. Emma, as you move. Thank you. The next one is Aisha Nasanga, who is going to tell us about using PMTCT audit tool to increase the proportion of eligible HIV-positive pregnant women and mother-infant pairs receiving all the services at Nyashuha Health Center 4 in Ibundibujo. You're welcome.
Thank you. Good afternoon, everyone. Nasanga Aisha, my name, from Nyauka Health Center 4, Bundibujo District, and I'm presenting to you IT using the PMTCT audit tool. Using the PMTCT audit tool to increase the proportion of eligible HIV-positive pregnant women
and mother-infant pairs receiving all services at Nyahuka Health Center 4, Bubukwanga Health Center 3, and Vundibujo Hospital in Vundibujo District. Those are my co-authors. The PMTCT services are very crucial in the elimination of mother-to-child transmission of HIV. The PMTCT audit tool for quality was introduced by the Ministry of Health in 2022 as a tracking tool to ensure all services are provided to eligible HIV-positive pregnant women and mother-infant pairs. So from the baseline data that we collected in July 2022, it indicated that PMTCT service quality was at 60% in June 2022 at 3 health facilities in Vundibujo District. Those are the facilities I earlier talked about on the. And we found out the major gaps following the root cause analysis were staff changes, knowledge gap on the particular services, the interval on when to provide the services, and ignorance on the use of the audit tool. So those are the methods used to bridge out the gaps. There was training of maternal neonatal child health staffs on all service packages, because most of them didn't know what exactly to give to these people. We formed work improvement teams, oriented the staffs on the use of the audit tool. We went ahead and did daily review and updating of the PMTCT audit tool. Here, we had to analyze the gaps, generated CQI projects for the particular gaps identified, and then we developed solutions for the gaps we have identified. And then we went ahead and made a weekly display of line lists for clients expecting services at clinician tables. This was done every clinic day. And we would go ahead and make reminders. There was a mistake to staffs, not clients, to staffs to offer all services expected at that particular visit. The focal person would make reviews about completeness and documentation of client charts and the audit tool. So the peer mothers would go ahead using the dashboard for the audit tool, because the audit tool, those of you who know how to use it, flags services every person is eligible for. So the peer mothers would use the dashboard for the audit tool to provide psychosocial services, retrieval of client charts a day before the clinic, feedback meetings with the peer mothers. They would give us feedback of how it went, and that was our run chart. That is what we managed to get. We improved from 60% in May 2022 to 94% to May 2023. Okay. As the discussions we had, routine use of the audit tool enabled prompt identification of HIV-positive pregnant women and mother-infant pairs eligible for particular services, and targeted QI interventions that improved all service provision. Okay, those are the lessons we learned. The PMTCT audit tool is a quality tool to guide the provision of all services for HIV-exposed infants and PMTCT mothers. The PMTCT tool is a planning tool at the facility level, and it avails all inputs for clients. The PMTCT audit tool guides real-time follow-up interventions for mothers with missed appointments. The audit tool guides and informs targeted QI interventions to improve service quality for HIV-positive pregnant women and mother-infant pairs.
4 minutes.
So we concluded and said the implementation of the audit tool greatly improved service quality, which is a key factor in ensuring better client health outcomes. And we recommended the Ministry of Health, at the Ministry of Health level, we have to scale up the use of the audit tool to guide the provision of quality healthcare services. And thanks goes to the Ministry of Health because they helped in bridging the gaps that were in using the audit tool, because previously it was manual, and currently it is now generated from the EMR, which is more easier. Facility level, use the audit tool data as part of the performance review meetings. Generate printed dashboards for client literacy message packaging on all services and why they should always receive all the services. Acknowledgements go to CDC, the donor agent, Baylor Uganda, more especially our cluster head, Dr. Benjamin Mwanika, the QI focal person, Dr. Farida Akuju, and Juko Richard. Individual local government, the DHO, Dr. Kiita, and all the QI teams at the different facilities, Bobokwanga, Nyahuka, and Bundubujo Hospital.
Thank you very much. So, an applause for her. Please, Karibu. Thank you. In combating antimicrobial resistance, a success story in pediatric ward, Lira Regional Referral Hospital. Stephen Aupa. Okay, next.
Thank you so much. My name is Apio Betty, but in that book you're seeing the name of Stephen Aupa. Stephen has lost his dad 2 days ago, so he couldn't be with us. I'm from Lira Regional Referral Hospital. From Lira Regional Referral Hospital, with me in the house I have team members. I have, as the IT is still looking for my presentation. In the house from Lira Regional Referral Hospital, we have a principal hospital administrator with us, and also the senior principal nursing officer. You're all welcome.
IT, please.
So we are presenting the impact of microbiology services in combating antimicrobial resistance, a success story at pediatric ward, Lira Regional Referral Hospital. Below are the list of authors, and the sub-theme is D, health infrastructure. In our introduction, microbial services are not routinely used to aid diagnosis and treatment of severe pneumonia in children. Routinely, children with severe pneumonia are treated with empirical antibiotics. So, according to the Uganda clinical guidelines, children with severe pneumonia are diagnosed basing on clinical presentations. For example, fever, cough, difficulties in breathing, plus one or more danger signs, which can be central cyanosis, altered level of consciousness, generalized body weakness, vomiting or failure to feed, plus others. Once this diagnosis is made, the severe pneumonia is treated with empirical antibiotics. What does it mean? Empirical antibiotics means the treatment of severe pneumonia is started before the causative agent is identified. So this success story details is for a case of 5-month-old infant admitted with severe pneumonia, and with the aid of culture and sensitivity test of gastric aspirate was found to have a fungal pneumonia. So the case presentation: a 5-month-old previously was well with no known chronic illnesses, not sero-exposed, was admitted on 25th of July 2022 with history of cough, fever, difficulties in breathing for 5 days, associated with generalized body weakness. According to the mother from the clinic where they first went, the child was tested for malaria and was found to be positive using MRDT, then was also treated with unknown IV treatment. Then from the hospital, the temperature was very high, that was 39.1 degrees Celsius. Oxygen saturation in blood was 79%, and the pulse rate was 160 beats per minute. And still in the hospital, the MRDT was tested, done, and it was still positive. On examination, the significant findings were severe respiratory distress, high respiratory rate of 85 beats per minute, and chest had bilateral crepitation, and the diagnosis or the impression was severe pneumonia. Then the treatment which was started, we initiated the child on immediately on oxygen using nasal prongs. We gave IV ampicillin 350 milligrams BD for 5 days, IV gentamicin 35 milligrams OD for 5 days, then rectal paracetamol for fever. Next. The progress notes. On the second day of admission, the child's condition worsened, so the child was changed from nasal prong oxygen to continuous positive airway pressure, which is another form of oxygen administration by use of oxygen mask. Then, as per the protocol says if within 48 hours on ampicillin and gentamicin, there is no improvement, we change to second line treatment. So the child was changed to high ceftriaxone 560 milligrams OD for 5 days. The NC was inserted for feeds with 87 mils every 3 hours. Then the rectal paracetamol was continued because the fever still remained high. On the 10th day of admission, that was on the 5th August 2022, the child was still bedridden and oxygen dependent on CPAP. Gastric aspirate was done, and the sample was taken for culture and sensitivity. Next. Methodology. A complete blood count was taken, and the significant finding was the white blood cells was raised due to infection, normal HB and platelets. Culture and sensitivity results, which was taken previously, it was released on 8th August 2022 and yielded gram-positive budding yeast cells, typical of Candida species. Then the child was switched to antifungal treatment, which was IV fluconazole 84 milligrams OD, and after 3 days of treatment, there was an amazing improvement, and the child was weaned off the CPAP, and the child was treated with IV fluconazole for 7 days, then discharged on oral fluconazole. Next. The results. The baby improved within 2 days of initiation of antifungal therapy, which was guided by culture and sensitive results. We were able to identify the actual causative agent, which was Candida species. So correct treatment was administered, hence rational use of antimicrobials. Then baby was discharged in a stable condition after 7 days of IV fluconazole treatment. Next. Discussion. Empirical use of antibiotic standards of care in management of children with severe pneumonia sometimes may not be so helpful. However, antimicrobial testing also has a role in diagnosis of children with severe pneumonia, especially when the child does not improve. Despite the prolonged hospital stay,
3 minutes remaining.
a definite diagnosis was made and child improved, and protocol for management of severe pneumonia was followed during the management of this case. Next. Lessons learned. Microbiology services play a very important role in disease diagnosis and management, and actual quality test results are key to proper patient's management. On conclusion, quality microbiology testing are key in determining the treatment outcomes and help in combating antimicrobial resistance, and the definitive treatment in resource-limited setting is helpful compared to empirical treatment. We recommend that we embrace rational use of antimicrobials to strengthen microbiology testing services at both government and private facilities in disease management for better treatment outcomes, be a champion and an advocate against antimicrobial resistance. The fight against antimicrobial resistance is a joint effort. Thank you.
Thank you very much. Yes. Thank you so much, Lira. This takes us to the last presenter, who is Tom Bategeka, to tell us about health information management as a tool to improve and sustain health systems in Uganda. Please.
Thank you, Chair. Dear delegates, ladies and gentlemen, I'm called Tom Bategeka. I work as a medical records officer on the General Hospital. At the national level, I am the president of the Medical Records and Health Informatics Professionals Association of Uganda, and I'm here to present to you an abstract on health information management as a tool in providing quality health services in the country. Health information management, which is abbreviated as HIM, has played a crucial role in improving and sustaining a good health system in Uganda, and is essential for effective planning, monitoring, and evaluation of health programs and policies in the country. And these are the key aspects for health information management. One of them is data collection and reporting. HIM systems have facilitated the collection, storage, and analysis of health data. This has enabled the healthcare providers and policymakers to have accurate and timely information about the health status of the population, disease burdens, and healthcare utilization patterns. This data serves as a basis for evidence-based decision-making, resource allocation, and planning. 2, well patient management. HIM systems have helped in recording and managing patient information throughout the healthcare continuum. This includes electronic medical records, health profiles, and treatment plans. Access to comprehensive patient data improves the quality and continuity of care, reduces medical errors, and enhances patient safety. 3, we have health information systems. Uganda has implemented several health information systems to manage and store health data. The District Health Information System, DHI2, is widely used for data collection and reporting at the district level. The system consolidates information from various health facilities and provides real-time data and decision-making. 4, we have health research and surveillance. Health information management is crucial for health research and surveillance activities in Uganda. It supports the monitoring and evaluation of public health programs, identifies health risks, and contributes to evidence-based policy making. 5, we have data analysis and reporting. Once the data is collected, it's analyzed and reported at different levels within the health system. This helps in identifying health trends, disease outbreaks, and areas that require intervention. Reports are generated to inform policymakers and health managers and other stakeholders about the health situation in the country. And number 6 is health information exchange. There has been need for sharing health information between different levels of the health system. This includes the exchange of data between health facilities, district health offices, and ministries of health, and it facilitates coordination, collaboration, and informed decision-making across different levels. And I just give an example of the graph there, which was showing that 13.3 growth of family planning activity in over the last 1 year. That's the graph I used in the other slide there. Then number 7, we have disease surveillance and outbreak response. HIM systems have enabled the monitoring of diseases, patterns, and trends, which helps in early detection and response to outbreaks. By tracking infectious diseases, HIM has helped in supporting timely interventions, resource allocation, and public health campaigns for disease intervention and control. And number 8 is health education and promotion. HIM tools have been used to disseminate health information to general public, healthcare providers, and stakeholders. This has helped in raising awareness about various health issues, promoting health behavior, and providing information on preventive measures and available healthcare services. Number 9, electronic medical records, EMR. The adoption of electronic medical records is slowly increasing in Uganda. EMR helps in digital management of patient records, making it easier to access and share health information within the health facilities. It also improves accuracy, efficiency, and continuity of care. In addition, as part of the digital transformation policy adopted by Ministry of Health, as enshrined in the National Development Plan 3, Uganda has made a significant effort with the guidance of the Ministry of Health top management, technical working groups, and implementing partners to implement the electronic medical record system, a process which it is ongoing, and its goal is to ease documentation, access, and retrieval analysis, and minimize medical errors, and safe exchange of health information for effective decision making. I gave examples of EMR as IAFIA, Clinical Master, Harris mentioned but a few. Sorry. This is another example of data analysis that is used to make a decision making. I just analyzed some data from Ndwigi Hospital, looking at deliveries for the last 6 months. And then also the map is also showing the same thing, as you can see, as an example of data analysis. In conclusion, therefore, HIM has been a essential tool that has helped in improving the efficiency, the effectiveness, and sustainability of the healthcare system in Uganda by providing accurate data, supporting decision making, and facilitating better patient care. And these are some examples of how data has helped me as a manager, where all the big people in this country have reached the hospital and have found some information being used. The first picture, as you can see, there was a PS who visited the hospital in 2021 with the Director General, and we were trying to analyze the data which was displayed on a notice board. In 2015, I was awarded with a gift from the President for managing health services using the data at the Ndwigi district. Then in 2022, I was also awarded as the winner of the Hero Award, which is Heroes in Health Award, 2022 from Allied Health. So, as I conclude, I have these words I use as words of wisdom that has encouraged the health workers to continue improving in what? In health information management. And we say, when we document everything, we improve everything. And then we achieve everything for quality health services. Thank you for listening to me, for God and my country.
Thank you very much.
As I conclude, I thank my the sponsors, family planning activity, which has enabled me to reach here and present it to you.
Thank you so much. As we welcome you this side, we give him a round of applause, which is befitting. Thank you. So this brings us to the end of the presentations, and it's time for us to discuss these presentations and I want to get questions, clarifications, comments, but you need to be clear, precise, and identify the person you are asking the question. So over to you, the audience. Yes, where is the mic? So we are going to give a round of about 6 questions in the interest of time. So I'm counting, well, from this side, from my extreme left, number 1, number 2, number 3, number 4, number 5, number 6. Hey. Thank you. So let me do it again. I want to count from the extreme left. Number 1, I've not seen that one. Number 2, okay, being masked by the camera. Number 3, number 4, number 5, okay, number 6. Shall give you another round. So, where is the mic?
I'm the one having it.
Okay.
So thank you very much for the presenters. My questions goes to Emma Welihe. I would wish to hear on how do you handle the pap smear in case there is need and biopsies. 2, what is the turnaround time for the results of biopsies? Thank you.
I'm John Kamapena from Kawe Center for Shema District, and my question goes to the lady who presented on behalf of Stephen from Lila. From the presentation, we saw that baby had a positive MRDT, both from the clinic and from the hospital. And according to the management, we didn't see anywhere malaria being managed. So I was asking myself, was malaria ignored because of pneumonia, or antibiotics that were given? Were they able to cure malaria? That was my question.
Thank you. Loud and clear. Next question. Yes, here in the middle. Oh.
Yeah, thank you very much. My brief question goes to Aisha Nasanga, yes, who presented about the audit tool. I saw a comment on engaging the peers. I just wanted to know, because I am so much interested in how you've tried to institutionalize this at the 3 facilities that you mentioned. I just want to know how you brought on board the peers, or you gave them some kind of formal training on how to pick out online list mothers who have missed a particular service and they are able to look out for them. Thank you. Using the audit tool.
Thank you. Next.
Thank you very much, all the presenters. My question goes to Emma. My name is Kamsha. I come from a region that has very many mentors, but who face a problem of going to sites for mentorship. Subsequently, the sites are not mentored. The reason is finances. We are having a theme of innovations within resource-limited settings. Whereas you told us those who were able to support you, what would be the innovations that would improve on financing for mentorships? Or how would one conduct mentorships amidst resource limitations? Thank you very much.
Thank you.
Thank you very much. I'm Innocent Arenitwe from Rushere Community Hospital in Chiruhura. My question goes to Mr. Tandi Suwala Tom. I've seen a number of awards given to him, and I really congratulate him. But I have a question about his position as a president of people handling health records in the country. What have you done as a president to also build the capacity of those colleagues under your leadership to make sure they also turn up on such audiences and present what you have presented? Thank you.
Thank you.
Thank you very much. My name is Prima Niwampire, and I work with TASO Uganda as the National QI Coach on the Catalyst study. My question goes to Tom. Thank you for the great presentation. And the question is about the prong of EMR and health information exchange. Now, we understand the critical role that these two prongs have towards continuity of quality of care. But the challenge that we see, especially in the private facilities, is that we have we keep the medical records of our patients, and we find that if I receive a patient from a different health facility, which is private, I'll have to go through the whole initial process of obtaining history. Yet this information is available maybe in the medical record system of a different facility. So we've seen something in different countries where there is exchange of this information across facilities. Is this an area of innovation that maybe we could think about, and how can we be supported, or you as the president, how can we have this across, put across? Thank you.
Thank you so much. The presenters of today, I'm Dedan from Ankole, RPHS. My question goes to someone from Bukwanga for PMT City Audit Tool. I'd like to learn from you if you could have encountered any challenges with the audit tool you're using, and how did you go about it? Also, with EMR integration or with audit tool, would like you to let us know whether it has how it has solved those challenges that you had before. Thank you.
Okay. Thank you very much. I am Esther Nambala Kasada, Regional QI Officer, Mbale Region. My question goes to Lira Regional Referral Hospital. That was so interesting. I have two questions. One, how functional is the work improvement team in pediatric department? And how functional is the work improvement team in the laboratory? And how are they working together? And then my other question is, so how many other children have benefited from the antimicrobial testing besides the success story that you've given us? Thank you.
Thank you so much. I'm Isaac from Kigezi Healthcare Foundation, and we are being supported by LSDA. My question goes to Aisha, who presented on the audit tour. One comes with 3 facilities that they are supporting. We understand there are dynamics under which health workers are working, and also the clients have also other things attached to either this missing of the services, but these are 3 facilities. I would like to know if the 3 facilities were facing the same challenges, and maybe they were using the same strategy so that they can achieve from a certain, from 60% up to the same level at the end. Number 2, audit tools are not also becoming sufficient enough. Maybe it goes also to Ministry of Health. When it comes to other services being provided, especially in the PNC, when it comes to immunization and so on. I don't know whether they are going to have this also modified so that it captures much more services. But also to her, how is she ensuring that also these services are provided alongside what is provided for in the audit tools? Thank you.
Thank you very much. Presenters, I'm Philip Mamia from Buejo. My question goes to Esther, who presented about PNC attendance. This happens to be a challenge at my facility, and you mentioned about poor client flow. I wanted to know your staffing levels, especially with the midwives at your facility, because back at my facility the challenge is the limited staffing. We are not staffed to capacity, and if it's the same case at your facility, how have you maintained good client flow with the limited staff, especially with the midwives, because PNC is purely done by the midwives? Thank you very much.
Thank you. I think we are getting out of...
Hello, Dr. Panda on this side, Stephen. My name is Dr. Jonathan Wangisi from Bale District Local Government. A quick comment to Tom. I missed a bit of your presentation, but I have a few comments to you and maybe some officials from the Ministry of Health. Tom, first of all, I want to congratulate you for being able to be there and get an abstract through as an HMIS person, aware that data or data use is at the foundation of all quality improvement programs. Actually, I'm very excited that at least we have a health information person at the podium, but also you happen to be the president of the health information team in the country. Now, my question relates a bit to what my colleague asked, but maybe in a different form. In your view, Tom, as the president of the Health Information Assistant Association, whatever, when you look at the increasing need for healthcare programming to partake more of data, and in view of the current qualifications of the health information assistants at certificate level, given your own experience in the training and maybe plus or minus additional training, and where you as a president, do you think we have done a good matching of the certificate vis-a-vis? We want to put a doctor at a health center 3 because to match with the increasing needs of that level, and we are still having a certificate person, with due respect, at that level. Do you think that is good matching, or how do you want to address the ministry? Because I'm sure the ministry team is here. We are talking about a lot of data, but my experience you may be wanting to squeeze water out of a stone, but I don't know what your experience is. Thank you.
Thank you for the. Okay, let's have this lady.
Thank you very much. My question or concern goes to the colleague who presented something on the antimicrobial resistance. Now, the risk of antimicrobial resistance currently, I think, is quite very significant in the country. About 70 to 80% of our patients of the population get their medications from lower level health facilities, where the laboratories are very basic and in fact almost even non-existent in some. And so they rely on empirical treatment for whatever infections that our patients present with. Another proportion of the population does self-medication. When somebody is having a sore throat or some chest pain, just walk to a drug shop and pick whatever antibiotics they can find there and start swallowing. Now, I was just wondering, did you think of possibly using the laboratory hub referral system to consider referral of samples for culture and sensitivity to the regional referral hospital in order to improve access and accuracy of treatment? Thank you.
Good afternoon. I am Nachiboneka Winnie from Rubaga Hospital under UCMB. My question goes to Tom. The HMIS tools you have shown us are at national level. We have come to learn. Could you help us draw more innovations you have put in place such that I can easily relate with what you have presented to today's theme, such that I can have a take home?
Thank you. Good evening, everyone, and thank you, presenters. My question goes to my sister from Leah. Two of them. One, how have you encouraged the regional referral teams to uptake the microbiology tests? Because it is a learning. This was the best practice of a case, but we need to look at the entire facility making use of microbiology testing at that level. Secondly, what are the challenges that you have encountered in having microbiology tests done outside the regional referral, being that it's a hub that looks at other facilities? Yeah, thank you. My name is Ismail Hassan Kagoro. I work with Bela Hoima.
Thank you. This juncture, I would like to also give the mic to the people online. In case they are there, please. Want to know, and then the presenters can respond to them. The participants online, please. That has come from online participants, and it is from Abubekar Kauba, and it says to all presenters, how shall you sustain these good innovations? I think that's all. How shall you sustain all these good innovations? And two, for Dr. Werike, mentors require facilitation, so the intervention is finance intensive. How do you sustain this? That's to specifically to Werike. Any more questions from online? Then to Bunampago Health Center, Aisha, who presented, what were the reasons for non-screening or unclear appointments? What did you do exactly? Then for all presenters, how do you attribute your improvements to the change ideas? Otherwise, how have you taken care of random variation? To all presenters, how do you attribute your improvements to the change ideas? Otherwise, how have you taken care of random variations? So I think now we can have the presenters respond to the questions, and we should take the order as we presented. Process, please, but be brief.
Thank you so much, Chair. I had two questions, one from the audience and one from the virtual attendants. The question from the audience here was, it was an issue of poor client flow. How did you handle poor client flow at your facility with few midwives? I want to acknowledge that human resource capacity is a very big challenge, including my own facility. I have only 3 midwives, qualified midwives attached to my facility. But amidst all that, I have to give outputs that are in comparison with the targets given. So I have leveraged, just like I shared in the presentation, I have leveraged on community structure very heavily, attachments of the VHTs on a rotational basis. Every other day, at least I have a VHT attached to the facility, and I also have support staff of other cadres that would actually do the non-technical bit of directing, of directing clients to where they need to go for particular services, of giving health education sessions, of basically quite a lot that is not so really technical. So I've also handled the issue of human resource availability in terms of controlling the duty roster. First of all, it's approved from the district head office for ownership. Then I have to make sure that these individuals supposed to be on duty are actually on ground, but also attaching them to points of work, because there are instances of them being on ground, but actual outputs is not felt. So you have to hold them accountable enough by supervising their availability at the different points of work, but also interesting them to work targetfully. Share these targets by individuals, and even when doing the evaluation at end of week or end of month, be able to attribute what outputs each of the midwives is contributing to the overall performance that we see. Then we also have a technique of gentle persistent pressure. Some individuals tend to get into a laissez-faire style in terms of performance, but as a leader and topmost leader in the facility, you continuously apply gentle but persistent pressure to cause results from such individuals that tend to sleep on duty. Then at Center 3 still, where I operate, we do not have specialization of individuals. You may be a clinical officer or a nurse, but when duty calls, we all traverse the different points of service care. So basically that is what we did in terms of revising the client flow, including a step where we could do the screening, which is not necessarily done by a technical midwife, but even a lay worker can ably ask or screen out and see that this mother is actually due for PNC at any time interval according to the cascade for PNC. The other question was about what were the reasons for non-screening. I think this participant must have logged in a bit late, because this was very well aired out in the challenges, in the root cause analysis, and the what we did. So probably reach out to the presenter to have an engagement on what we did, how we came up with the root causes, and what we did to address the root causes. How shall you sustain these good results? I think this was for all of us. We realized that in what we shared, we are using resources that are amidst our own control as a facility, and so sustainability will not be an issue. But also, I'm happy to note that as a facility, we have embarked on weekly data review every Monday morning. So that alone is going to be an awakener. Every time we are falling a bit away from the targets, we can be able to revitalize or re-strategize or on doing better in terms of hitting our targets. I thank you.
Thank you so much. So next is Emma.
Thank you, moderator. I had 3 questions targeting my presentation. Just to start off, the first question was about pap smear and biopsies vis-a-vis turnaround time. Now, just to provide a highlight as LSDA, our focus majorly with the PNFPs has been in terms of prevention and timely treatment of precancerous lesions for the women accessing ART 25 to 49 in the PNFPs. Now, prevention, we are looking at timely screening, identifying those, of course, that have that have no cervical cancer lesions, and those with lesions, the precancerous ones, we're looking at CIN, being able to be treated, of course, looking at the common treatment modality, which is thermocoagulation and use of the lip, and those are the most methods we're using in the PNFPs. However, key to note, as a partner in the 7 sub-regions, we work in collaboration with the rest of the partners. This includes the IP supporting the public facilities, but also the regional referrers and the different DHTs. And particularly our roving mentors, some are actually from the regional referrers, but others actually coming from the DHTs and the public facilities as well as PNFPs. So that interplay of mentors vis-a-vis collaboration has made it easy for us to ensure that those that with advanced cervical cancer or suspects for cervical cancer are referred timely to the regional referrals of the district hospitals for actually biopsying and the follow-on pathophysiological tests that are required. But key to note, for the PNFP's focus is majorly on VIA and HPV screening for cervical cancer, while ensuring that referrals are effectively done for those that need follow-on care. Now, the rest of the other 2 questions were hinting more to sustainability. The first one, I wanted to know how we can conduct mentorships amidst resource limitation, and I think that speaks to the element of sustainability, and I think that was also highlighted on the virtual platform. Now, you really realize it's impossible to build capacity without some resources. But of course, as given the resource restrictions and challenges, we are looking at how can we best create efficiencies while ensuring that the knowledge is disseminated, the skills are equipped to the health workers to ensure that there's continuity of services. Now, among the ways we are looking at following the roving mentors, of course, they did focus on sites with capacity gaps. And what we've now done, just like I highlighted in the presentation, was 1, creating regional-based WhatsApp groups. Now, those have provided an opportunity for routine interaction and knowledge sharing between the different peer-to-peer, but also the technical teams from LSDA, in addition to the mentors themselves, where we're able to really dissect performance challenges, as well as also addressing issues around commodities and supplies, and also effectively supporting referrals. The other issue has been, as following the trainings and the follow-on capacity buildings or mentorship we had on-site, we have highlighted, we identified teams that had different strengths. Of course, as PNFPs, we have a challenge of attrition, but also importantly, we have had challenges around the very frequent rotations of staff. So what we have looked at is really working with the management of the different facilities to ensure that there's ongoing peer-to-peer capacity building, and we feel that is actually an opportunity for sustainability, that even when the partner is not there, the teams on ground are able to continue orienting each other. And that's how, among the mentors we're actually bringing to support other sites are coming from. So there's continuous capacity building in the different facilities, even without the partner actually coming to bring external support. Just final, moderator, is what we've done also as an innovation is attaching the low volume facilities to the high volumes. And this we are looking at in terms of mapping and ensure there's proximity in these facilities, so that it's a walk or a mere very affordable transport refund for health worker to come from a high volume to low volume facility to provide a mentorship, and then, or even the one from a low volume to move to high volume and have this done. I think those are some of the things I would really highlight. Thank you.
Thank you so much, Emma. So can we have, I think Aisha had a handful of questions, and I would like her to do justice to them. Aisha, please.
Thank you, moderator. My questions are quite a lot. The first question was asking how the peers get to line list the mothers due for services. It was coming from this side. I'll respond by saying, first of all, I thank our implementing partner, Baylor Uganda. It has done a great job by employing facility-based peers in every facility. So these peers are always available. So what we did, we took them through the audit tool. Since we all know the audit tool just flags when someone is due for a service, it will show red. Or if someone will be due in a certain particular time, it will show yellow or blue. It colors out. So we oriented them, and they know what to do when they reach the dashboard. The next one was asking if we had any challenges with the audit tool. Yes, of course. The previous audit tool was manual. This was to do with entering the client's data from name to the last. And that was a very big challenge to the high volume facilities like the district hospital and Nyauka Health Center for being a very big art site. So that was the main challenge we got. And when the EMR integration came in, it became easier because everything is already in the EMR. You just need to update the client chart and then update the EMR, then everything is sorted. Then the other one was where these facilities having the same challenges. You'll agree with me, when it comes to ART services, most of the challenges cross-cut all facilities, even if it is not from Bundibujo. Those who work in ART can be my witnesses. Most challenges are always the same. So yes, we were facing almost all the same challenges. Then the other one for integration of other services that are not in the audit tool, I think that one will be answered by the Ministry of Health because it deals with that. And then for our side, it is about quality improvement. So we would make sure all the services are really provided.
Thank you very much,
That's
Aisha.
it, I guess.
Aisha, thank you so much. So we got some information that Stephen Aupol lost a father 2 days ago. I would like us to observe a moment of silence in respect to that. Just a moment of silence, because Stephen was supposed to be here with us, but he lost a dad 2 days ago and not with us. So 2 seconds of silence. May his soul rest in peace. So next is the one who represented Stephen.
Thank you so much. Thank you very much for the question. Question 1 was about a positive MRDT. Yes, the MRDT was positive from the clinic. The child was managed with Coatem. Then still it was positive from the hospital. So we know that if, The test with MRDT can still be positive even after 3 weeks of antimalarials. We also did a BS, which was negative. That's why we did not include it under the diagnosis, because we did not treat from the hospital again. A question on functional weight. Yes, there's a functional work improvement team in both laboratory and pediatric ward with a good coordination. And how many children have benefited from antimicrobial testing since then? I've not been able to get the data, but I must say so many have benefited from this, and so many lives have been saved. The challenge is being a regional referral hospital. Being a hub on using microbiology services. We have, sometimes we run stock out of reagents. And how shall we sustain this the good innovation that we have presented? With the help of the administration, we shall identify some of the identify some of the challenges which we shall work on. As always, administration has been working together with all the units to make sure whatever we do is sustainable. Thank you.
Thank you so much, Rila. You want to add something? So, please, go ahead. He's from Lila, so proceed.
Yeah, Esther asked that, is it only that child who has benefited? No. There are so many children who have benefited from microbiology services because we offer services ranging from blood culture, CSF analysis, and effusions. So it is not only that child who has benefited, there are so many, even adults. Then Dr. Lemukole, DHO of Moroto, asked about antimicrobial resistance. I would like to inform you that we have built capacity in the Lango sub-region of TOT on antimicrobial resistance, and I'm happy to note that to inform you that I'm one of the trainers of TOT for Lango sub-region. Referral of samples is still low. However, whenever there is an opportunity for either meeting, hub review meeting, or any other forum, we don't hesitate to talk about antimicrobial resistance. And in those forums, usually we take trouble to present data we have analyzed using a software called WUNET. Then there was another question by Ismaili. He said, referrals we have a challenge of no referrals from lower facilities, but it's still the gospel is on. Wherever we have opportunity to meet, we usually talk about referral of samples. The challenges we have got, limited resources, that was by then, ranging from biochemicals, culture medias, antibiotic discs. But as I speak now, if you compare the stock of supplies we have in Uganda, we are at 98.9% stocked. You can come and verify from there. Then, usually whenever there is an opportunity for a meeting between clinicians and lab staff, usually we take trouble and we present data on susceptibility and resistance of antibiotics, on commonly isolated antibiotics. That one we do it. Even we have what we call a parliament in Lira every Wednesday. in charges, area managers meet, and usually slot is given whoever has something to present, and the microbiology department, we have done so several times. Then during CMEs, whenever there are new interns deployed to LIRA, we take trouble to take them through various services we offer in microbiology. I think I can stop there in the meantime. Thank you.
So much.
Yeah.
Thank you so much for that addition. So that bring the mic to Tom.
Chair.
Please.
Thank you. Thank you, Chair. Can I proceed?
Please.
Okay, thank you. I have some questions here. The first one was about how am I motivating or training my colleagues to be at the level where I am. As you are aware, medical records people and health informatics of this country who are working in government and other health facilities were left out of the enhancement. These are the various reasons which are a bit political, and others would not understand them. But we are trying to maintain the spirit of work, because by virtue of our work, we are not supposed even to go for leave. You find one person is even at the Center 3 or Center 4. Whether you are sick, you are supposed to come back and report according to the timelines. If it is a Monday, you have to report weekly report. If it is the end of the month, before 7 days, you must report the reports. So I have encouraged them to continue doing their best as government is looking into our issues of salary enhancement. And what have we done? We have a network across the country where every Monday we have all these review meetings. We discuss. If there's any member who has any challenge at his or her place of work, he puts it across, and members help him or her to make sure that thing is handled. We have even a slogan that any challenge to one of us, it is a challenge to all of us. So we are ever trying to discuss these issues as far as our work is concerned. I've also tried to encourage them to continue with the studies. If you have a certificate, go for a diploma. If you have a diploma, go for a degree. So this is the question I'm answering. The other question, where the issues of certificate at the lower facilities. I would like to inform delegates here that medical records people, by the virtue how they were recruited in service, others were required in some certificates in the medical records, and others could require diploma. But as we talk now, among the cadres we have people with the masters. So it's a matter of regionalization, and to make sure if they want more qualification for purposes of doing quality work, it's upon the government to do that. Then my innovations I do at work. Basically, I have tried to explain to my members and members of staff I work with that data is everything. Data is food, data is money, data is blood. So long as you are working something in the hospital, you must embrace it. Without embracing it, then you are not working. So what we normally do is, I always have quarterly data review meetings where we discuss performance of individual health in charges. At the end of it all, we share and we award the best performers. Where there are gaps, we find a way of how to address them. Members here, even they have delegates from here who have ever visited my facility. We see how we do things every morning. We have meetings on the Mondays and so on. Then we also try to document the best practices we have. Where we can maybe say ABCD is not doing very well. Please, can you try to improve here and there? So the in charge, the facility in charge, the MS, is always responsible to come and to review our dashboard at the end of the month to see how we are performing, following the indicators we are monitoring. Then on the issue of EMR and health exchange, as you are aware, there are so many systems that are coming up, all of us looking for one thing, trying to harmonize our data. And in the future, I hope that at the end of it all, we shall leave paperwork. We shall leave these other registers, and then we go all of us electronic, so that we can doing only electronic work. And as you are aware how systems operate, you cannot duplicate any information in the system, and everything will be there. So a person from Wundubujo coming to Mulago, if my name is Tom, my information will be in the system to make sure I don't go back to look for that information from my hospital where I've come from. But otherwise, I'd like to thank you that continue supporting the medical records people, because they are going through a lot. However, we have hopes at the end of it all, our issues will be looked into too. Thank you very much.
Okay, thank you so much, Tom, for that comprehensive response. That being done, having been done, I think I hand over to Basaja Tevadiba for the next steps. Thank you.
Wow. Wow. Let's give a round of applause to our session chair, Stephen Pande. Thank you so much. And of course, you couldn't do it alone. We had Esther. Esther, you can wave to members and they thank you. They applaud you. We had also Doreen. We had Aisha. Then we also had soft-spoken Aisha. Then we also had Stephen, not the Stephen here. Then we also had Tom. Tom and the name? Bit. And also we had Betty in that order. So thank you so much. You have been awesome. So we have come to the end of day 2 of our conference. And as I speak now, it's time for break tea. And of course, we shall leave at leisure. Nobody is going to force you to go away. But for those of you who are presenting posters, you pick a cup of tea and a bite, come back to your poster, and in case there are any delegates who still want to interface with you, interact with you as far as the work you did, which is exhibited in the poster, please be available during tea time. And when the time comes, then you can go out to the lakeside, to the town, and everywhere, but stay in Entebbe, enjoy Entebbe, and then come back tomorrow. Tomorrow is the last day for this work, for this conference, and just to give you a highlight of the day's happenings. First of all, in the morning session, we shall have the session chair will be Dr. Yai Alfred, who is the Director, Jinja Regional Referral Hospital, who will be chairing that morning session. And amongst the keynote speaker will be Professor of Pediatrics, Professor James Tumwine from Kabale University. So he will be there to talk about minimizing medical errors in health services in Uganda. That is critical. There are a number of things which we can work on to minimize those errors, because life is life. But of course, before that, there will be a number of presentations, 2 of them, an overview of the MOH digital health strategies by the Assistant Commissioner in charge of Division of Health Information, Paul Mbaka, and of course an overview of the Health Facility Quality Care Program implementation in Uganda, which will be none other than the Acting Commissioner, SCAP, Dr. Martin Sendiona. Briefly, that's how the morning will be, and please, let's be here between 9 and 9:15 just to do the registration, and then from there we kickstart the program. And then, of course, after break, we shall have the breakaway sessions. And the thematic areas for tomorrow are basically for Ziba Hall, which is here, it will be medicines and health supplies management and health management information system. And then in Kama Hall, it will be improved service delivery models and health infrastructure. So please, please, tomorrow, make sure you also visit the other breakaway session. We're having a challenge. I don't know whether it's a problem of moving to the other side and taking up the stairs, but there's a lift. So please don't say that, this is my plot, I'm not leaving this plot of land because I'm enjoying the ambience here. Even there it's also enjoyable. So let's try to have that balance. It's a request because you have noted that even, surprisingly, even the presenters who are supposed to be there have ended up staying here to listen in.
Tablet. Tablet. I think we need the group photo here with
I'm
my
going to
team.
organize that. So that's how bad it has been in the afternoon. So let's save the situation tomorrow so that we have a very nice day. And of course, after the after break sessions, the chairpersons will be mentioned. They are already there. For me, I just wanted to highlight, as you know, that the breakout session after lunch, after break, there are always many presentations around 10. So please, let's observe time and be in the right place at the right time. And of course, towards the closing, which will be in the afternoon after lunch, there won't be any moment for poster presentations. So they are done. And I think if there are no more presentations for tomorrow, these ones can stay. They can stay in the exhibition. My assumption is that the presenters of these posters will be here tomorrow as well. So they can stay on. And then, of course, in the afternoon after lunch, we are going to have an early lunch. So that we can start with the panel discussion, which we have a number of key panel discussants, which are listed in the program book on page 21. And of course, we need to do that well in time so that we can have the official closing ceremony just soon after around 3. Then we can end at around 4 with break tea, group photographs, chatting, networking, and so forth. So that's it. I just gave you a snapshot for tomorrow's program, just to make sure that you are motivated to be here tomorrow in time by 9. Please be around and make sure that you register. The other aspect, there has been a request for the presentations, soft copies. Everybody wants a flash to plug in. I mean, we are around 400 delegates or 300 delegates. It's very difficult to start moving with flashes, 300 flashes to plug in and copy. It might be very difficult. Even if it's your machine, you wouldn't love that. So what we are going to do, we are going to make some arrangements. They will be compiled. This presentation will be compiled. And then there will be a link which will be shared. I'm sure all of you have registered, and it will be shared maybe towards the end of tomorrow in one of the sessions, so that if you want any presentation, you just go to the link, download. After all, there is free Wi-Fi. The password is MOH in capital letters. So leave this place when you have downloaded everything, either on your phone or on your laptop. Thank you so much. God bless you. A good evening. And the conference is adjourned until tomorrow morning. Enjoy the tea, interact, network, but don't leave Entebbe City.